So, when we compare these two things, organ preservation and total laryngectomy, hardly there is any difference between your success rates. But whenever you do a total laryngectomy, you are almost 100% sure that you are not compromised on your cancer. Oncologically, you are safe. You are very safe oncologically, and you have a clearance. Oncologically clear. Now, the third point we also need to understand is now in the new era of the endoscopic excision, endoscopic laser excision. This is an endoscopic laser excision is an excision from inside out. You start from within inward. Laryngectomy is the one where you are operating from outside to inside. You are opening the larynx, you are doing almost, you know where the lesion is, and you are operating from outside to inside. Whereas where you are doing an endoscopic procedure, it's an inside-out technique. From inside you are going up to the level of the thyroid cartilage and trying to remove as much as you can. Very good technique for a mucosal lesion, but once the cartilage is infiltrated, again it's not a useful technique. So, these procedures have got a limitations. So, endoscopic procedures as an excision are the function preserving surgeries. I have not called them as the organ preserving techniques. They have to be a function preserving technique. These techniques have a limited indication of this kind. But most of our patients land up in a scenario where they require a total laryngectomy, or otherwise what we regularly do is a wide field laryngectomy. That is what we call it as an interjugular resection. We clear 2, 3 and 4 groups of lymph nodes along with the larynx. So you will end up doing a wide field laryngectomy, almost clearing both sides, you are clearing 2, 3, 4 nodes and removing the entire larynx. So what is this going to leave with you? When you do a total laryngectomy like this, you are left with a tracheostomy. The most important thing you are going to have is the tracheostomy. So what is going to happen now? Now this patient is not going to breathe through his nose again. The entire upper respiratory passage above the level of the larynx totally is gone. Now you have a totally altered pathway for the respiration. That means he is going to have a permanent tracheostomy. How many of you have seen a laryngectomy? Just raise your hand. Right. So, you are left with the permanent tracheostomy, number one. And number two, you are going to have this voice and the speech are lost. And number three, you will have problems. To certain time, you will have problems with swallowing. The permanent disfigurement, because the entire Adam's apple is gone, and the laryngeal prominence goes, and you have the physical disfigurement. And there is a lot of psychosocial adjustment problems. The problem here is going to be, he is not able to communicate, he is not able to talk to other people, so he has a lot of psychosocial problems. Very usually this is on third or fourth day after the laryngectomy, usually it hits them. Till then they usually will be a stormy post-operative report, and once the stormy post-operative report is over and patient realizes that he doesn't have a voice, then actually it hits. So these are the problems which you are going to face in the long run. Main thing here is the altered respiration. You also have to understand one more fact is you are going to remove his complete nasal function. One of the important nasal functions is olfaction and the flavor. You will not be able to appreciate the flavor. Flavor is a combination of olfaction and taste. You will not be able to appreciate the flavor at all. So these are some of the lifestyle problems he is going to face. He has got functional problems, he will have lifestyle problems. So both these things need to be addressed. So you are going to remove, what are you going to do in a total laryngectomy? You are removing a natural voice source. This is a natural voice source you are going to have. That is, you are going to remove the voice box. Right? Larynx is in the center of the upper respiratory tract and the lower respiratory tract. This is what I mentioned sometime back. Connects both the respiratory tract. It compromises both the pulmonary and olfactory systems. Once you remove the larynx, it's not one system which is affected. It is both pulmonary and the olfactory systems are affected. And totally the upper airway is short circuit. Okay? You have no use for the upper airway. And you are only going to breathe through your tracheostomy. So you have a problem of a permanent tracheostomy. So you have a lot of drying, you have so much of secretions in the trachea for the first few days, and then crusting in the trachea. So you have problems of a permanent tracheostomy. And also the air conditioning of the breathing air and loss of sweat. These are the common problems which you are going to face. So, earlier the laryngectomy patients have been going around without any voice. The first laryngectomy is credited to Wilcox in 1874. He has operated in 1874, and unfortunately, has not cancer larynx. He operated for some other reason, but he removed the larynx. And at the same time, he realized the importance of the voice and the speech, and he asked his junior colleague to do something about it. He supposed to have made a hole within the trachea and esophagus, and that created some voice, and that was the first attempt of a post-laryngectomy rehabilitation. Since then, now we have an established system of rehabilitation of the larynx, post-operative, post-laryngectomy. What we need to do is, we need to do it at the rapid re-establishment of the voice or fluent, intelligible speech. We can't have a complete normal speech. So what we are aiming here is a fluent, intelligible speech. This is what we are aiming at. So this is the Wilcox was done this in 1873. So the laryngectomy patient, simplest example of this is a patient whom I have operated in I have operated in 2001. He is alert, healthy and kicking. He has put on so much of weight. Actually, what you can see, he has a PMN gap, the wound is healed properly, the post-variation case didn't heal properly. We needed total laryngectomy, there was a wound problem, then we had to put the PMN gap. And now this is what is seen since last 15 years. So, it leaves you with basically two problems. One is euphonia and aphasia. He will not be able to produce voice, and hence he will not be able to speak. Aphasia and aphasia are different. Aphasia is loss of speech. Aphasia is loss of voice. And the permanent adjustment. And somebody asks you whether the loss of voice is a major problem or the permanent adjustment is going to be a major problem. What is your answer? Permanent tracheostomy or loss of voice, which is a bigger problem. Two different areas. Permanent tracheostomy is you will be a social outcast. If you don't talk to somebody, it's all right. But if you are having a tracheostomy and walking around, you will be a total outcast. Those were the days earlier. Now it's not. So how does a normal speech is produced? For the normal speech you require basically three things. You need a reservoir of air, that is the lungs. Right? Then you need a phonator. You need something which vibrates and creates sound. That's your vocal cords. That's your larynx. And then you need something to produce the speech. Right? You need articulators. That is you have all the articulators above the larynx. So this is how the voice is produced, converted to speech, and then the speech comes out. What happens in laryngectomy? Once you remove the larynx, what is going to happen? You have the reservoir of air, it is still intact. You haven't done anything to the reservoir of air. Right? And then you have the phonators are gone totally. You have removed the larynx. You have sent the larynx to the pathology department. And your articulators are still intact. So you have the articulators and you have the reservoir of air. And you need a mechanism to connect these two things to create a voice and speech. That's the basic principle of doing a rehabilitation. So what are the models for the post-laryngectomy rehabilitation? The most earlier method was the esophageal speech. It's a time-tested method. Is an esophageal speech. Every laryngectomized patient will be trained by the audiologist and the speech therapist. He will train the patient. You know how he is trained? He is trying to belch it, swallow it. Every patient is asked to come with a swallow bottle. Not that the real holy swallow bottle. With a lot of weight. He is asked to swallow, belch, and then belch the air back from the esophagus. So there are 2-3 problems in this. Some of the people have had a very good voice with the esophageal speech. Problem here is the esophagus can contain only about 80 ml of air. It is completely dilated also. Whatever type of ironing it occurs, it can only contain only about 80 ml of air. It cannot take more than that. So voice cannot be, the speech cannot be a continuous process. What happens is he starts, but he may not be able to complete the sentence. Again, then starts belching air, swallowing air, and then again trying to bring it out. So the continuity of the speech will be affected in esophageal speech. Then before the shunts and the devices, one of the techniques which I have told you is the Stepharis technique, and after term it is converted. Which is again replaced by a modified Stepharis technique. Again, all the surgical technique, all the shunts are between the trachea and the esophagus. The major concern here was how to make a static shunt a dynamic one. You are creating a mucosal tube between the trachea and the esophagus. Now the problem is going to be how to retain this integrity of the shunt, number one. Number two is how to prevent aspiration. The aspiration, the main problem is aspiration. So there are several other methods for tried. One is the creating from a static shunt to a dynamic shunt. That is what is actually do. Instead of a pure mucosal tube, we try to put a myomucosal tube. Have a mucosa along with the muscle, and the muscle contraction will prevent the aspiration. So you also have a little bit of inferior concentric muscle around the mucosa and try to create a myomucosal. The second thing which was being also done is placing the shunt at a higher level and lower level. If it is at a higher level in the esophagus, there is a chance of fluid directly flowing into the trachea. So the esophageal opening will be at a lower level than the tracheal opening. These are all various methods for right. But basically there are two problems. One is aspiration, and second one is to maintain the patency of the shunt which you have created. Further, they have got several devices, and these devices are so huge, not small devices. So these devices have become so huge. Then the easiest method they found out was make a buzzing noise around the larynx, which you just put it on the neck and try to articulate. This makes a buzzing noise and try to articulate. That's an artificial larynx or electronic larynx. This is very popular in India. There is a rehabilitation club in India. There is a rehabilitation club of India, and they give free artificial larynx. But the quality of voice is very poor. It's a mechanical voice. It's something like a robotic voice. It doesn't make any sense. The voice is very mechanical. So all these things are happening around, and at the same time, this particular procedure has come forward somewhere in 1978-79. That's 1970s and late 70s. This procedure has been described by a group of people from Indianapolis. Essentially, the process was started by, most surprisingly, a speech therapist. Eric Blom is the speech therapist. Singer is the surgeon. Mark Singer is the surgeon. But finally, the ball goes with the name of Blom and Singer. Blom is the speech therapist, and Singer is the surgeon. So what they have done is, they just came out with the idea of a puncture. This is not a shunt. There is a difference between a shunt and a procedure, and a puncture. Puncture is only a tiny opening which you are making, and this tiny opening you are going to retain the patency and put a wall immediately. That is what was the system developed by the Blom and Singer. That is the esophageal puncture. The esophageal voice we have discussed. Insufflation of air by injecting and inhaling, and then working out or reflecting the air back. That is the principle of and the success rate of attaining voice is about 40%. And only 80 ml of air can be taken in, and the voice will be a labored voice. You can't have a continuous voice. And the fundamental frequency of the voice for speech produced is very low. Artificial larynx will discuss about it. And now comes the surgical voice respiration. This is what we simply call as SVR. So we started with the shunt on the wall, and then came the dynamic shunts, and now presently we are at this stage. This is the surgical voice respiration by tracheoesophageal puncture. This is the first article came up in 1979 and then followed by 1980. This is nothing but an endoscopic shunt between the trachea and the esophagus, and the shunt is kept patent by a silicone valve. The silicone valve is nothing but a one-way valve. It's a one-way valve what you are using. So here is the larynx used to be here, which was removed. This is a permanent adjustment. This is the trachea and this is the esophagus. Now what you have created here is the opening between the trachea and the esophagus. On the posterior wall of the trachea, you just goes into the. And now by putting a wall here, a one-way wall here, you are now directing the air flow from the trachea through the shunt into the esophagus, where this particular area of neopharynx is going to vibrate and cause a voice and speech. Well, our experience has started way back in 85, 86. 1986 we had been to Indianapolis. He was my boss, Dr. Murali and myself, and our speech therapist. All three of us had been to Indianapolis, and we were trying in the technique. So the methodology was simple, and our speech therapist applied for the fellowship. He was told, you bring your surgeons also. Unless you bring your surgeons, you cannot train the speech therapist. So all of us have to go. So that was how we were pulled into the system. And now, we first started doing it in 1996 in KMC Manipal, and by 1989 when we presented the paper for the AOI Merck Award in AOI conference, we had about 170 cases. Because we had a large bulk of laryngectomies done. We used to do at least one laryngectomy a week. So we have a large bulk of patients. So we have done most of the cases as a secondary DEP, which I am going to tell you. So the technique, when we started doing this technique, there were only two people who were trained. One is Manipal group, and the other man who was trained is Ravi Nayak from September, he was in St. John. Only two of us were there. And we were all ridiculed by the Tata Memorial group. They said nothing doing, Mr. Major voice is the best voice, there is nothing you can do about it. And now Tata Memorial Hospital does the most number of laryngectomies, and they put almost every alternate. But people to change opinions, it takes time. So, what exactly is meant by the surgical wire suspension of laryngectomy? So, what does it mean? Either you can do it as a primary laryngectomy, at the time of laryngectomy itself, or you can do it as a secondary surgery. Now, what do you do at the time of primary DEP? Primary DEP, you do your laryngectomy. You don't compromise on oncological principles. You don't need to compromise on your oncological principles. You go ahead and do your laryngectomy, depending upon the staging of the disease. You have your margins cleared up. Either you have your margins cleared up. If you have a frozen section, you can get a margin clearance immediately on the table. Now, once you have that, once you finish everything, before closing, what you do is you create a regular surface fistula. And then either you can put the prosthesis on the table, or you can put the process after the stent is formed. So what you do here is you do the surgery, you make a opening between the trachea and the apex, because you puncture, you don't create a fistula, and then you put a stent. Now what we have done here is we have put a laryngectomy, now you have put this is one of the very old slides, so it just shows a red rubber catheter just going into in the beginning which we started doing it, we used to put nasogastric tube through this. The nasogastric tube normally goes to the nose, but we don't. What we were doing was we were putting the tube through the DEP by two stents. And we found there is so much of contamination around this. And every time whenever this feeding is given, it is creating so much of problems around the stoma. So we stopped doing that. And then we just put this tube, and once the wound heals, to take out this stent and put the process. So this is the principle of primary tracheal surveillance. You give a standard incision. The only thing here what you do is there are 2-3 small things which you do when you are planning for either a primary tracheal surveillance puncture or a secondary surveillance puncture here. The incision is standard, and the stoma. Whenever you are creating a stoma, you need a larger stoma. You need a larger tracheal stoma. How large is the tracheal stoma? It cannot be more than your thumb, patient's thumb. Because the problem here is he has to occlude the larynx, occlude the permanent tracheostomy, and then try to voice. So you cannot, it has to be smaller than the thumb. And then you need more space on the posterior side so that you will be able to do the puncture properly. So what you try to do is, you try to create not a round opening, tracheostomy. Instead of that, something like a D in the sideways, like a D in the sideways. the straight limb of the D comes at the upper aspect and the rest of it comes down. So you have more space on the posterior aspect and a lesser space on the below. So that is how you use. And you also you don't want the perennial constrictors to be tight. So you also do what is called the perennial constrictor management. These are some of the accessory procedures you do. So when you are doing a laryngectomy, there is no compromise. You go ahead and do laryngectomy as you do. Actually, if you are actually removing the larynx from the posterior part, the perennial nerves are all here. You will actually be doing a perennial neurectomy. Once you are cutting the posterior part, you are almost doing a perennial neurectomy. So the problems of the primary DEP are, you are interfering with the feeding. The feeding is going to interfere with the wound healing. So the wound healing is a major problem. And if this patient is going to require post-operative radiation therapy, and most of the patients do require a post-operative radiotherapy. So it is going to be a big problem. He will be left with a nasogastric tube for longer periods. So the motivation of the patient will not be much higher. He doesn't feel that he has a disability. So the motivation of the patients are very less. This is our personal experience. Now, there are 2-3 major problems you face when you are doing this procedure. One is, you have to do an extensive perennial resection. Sometimes when you start closing the pharynx and the esophagus, you are left with very thin pharynx. You extract so much of perennial mucosa for the sake of cancer. You are left with a very thin piece of tissue. The classical teaching says, if you can close the pharynx and the esophagus over the right tube, which is that much size of a lumen, is enough for swallowing. And surprisingly, in these patients, the voice will also be very good. You have a loose pharynx, again the voice is not that good. A little bit of tighter pharynx, neopharynx, the voice is usually better. And you need to remove the trachea because of the subglottic extension, and you have to almost do a tracheostomy almost at the level of the suprasternal notch. Then again you have a problem. So if you have to do extensive resection, you may not be able to do a primary DEP. So we can move on to what is called as the secondary tracheocerebral puncture, which is easier. Now what have we noticed here? These are the patients who are motivated because the patient goes home, he has a major surgical procedure, he goes home. Now it hits him that he is not able to speak. And these are the people who usually come back and ask for a prosthesis because they are motivated. He has realized that he has prosthesis once. So they are more motivated, so they usually come back and the acceptance rates are quite high. You need to select this patient. There are certain tests which can be done. Actually, a test is called as the insufflation test. It is a separate operator service which is provided by the company, and it almost gives you information whether how much voice the patient is going to get. So, two major problems what we are going to see here is the stricture of the pharynx which you have created, neopharyngeal stricture, or the cricopharyngeal stricture, or the cricopharyngeal spot. Neopharynx is above the cricopharynx. The cricopharynx is below. So either you can have a stricture at the level of the neopharynx, or you can have a stricture at the level of the cricopharynx. So if you find a neopharyngeal or a cricopharyngeal stricture, you have no alternative except to do an endoscopic evaluation before doing a surgical voice extraction. If it is at the lower level, you can also do a symptomatology. The Botox is, if you have not done a pharyngeal neurectomy or a symptomatology, the Botox also will relieve the cricopharyngeal part. So all the methods how, I think one of the questions questions last time given, I think last year or something, before last year the question given was, how do you manage tracheopharyngeal scar? So this is a neopharyngeal section. Either for a 2-3 methods is to a periodic dilatation till you have a satisfactory esophagus, food passage. The third major problem which you are seeing here is the stoma, stoma. Right? When I say stoma, don't get confused. There are two stomas here. One is the tracheostoma and the second one is the stoma between the trachea and the esophagus. There are two stomas. When we talk about stenosis, we talk about neopharyngeal stenosis and tracheopharyngeal stenosis. So, don't get confused. The stomal stenosis is mainly a problem with the tracheostomy becoming smaller and smaller. There are two things which happen. If the skin itself goes down into the esophagus, into the trachea. It just forms like a web-like. So these things may need resection, or you may have to do what is called as a tracheoplasty. You have to widen the tracheostomy. Another major problem, if you are going to irradiate the patient, if the patient slowly starts developing prisms, you will not be able to do a secondary tracheostomy. There are different methods of doing it. So, what do you do in a secondary tracheostomy puncture? Now, you are not opening directly. Now, you are doing entire procedure endoscopically. You do an endoscopy, that means you are going to put a scope into the neopharynx, then down up to the level of the gyropharynx. Then you puncture, you stent, and then put the prosthesis. So there are 2-3 techniques which are considered. Number one is straightforward PET. You put an endoscope, you put a stent. This is how you are going to put it. This is a schematic picture where you are showing this endoscope. This endoscope has gone into the esophagus, passed into the neopharynx, passed beyond the tracheopharynx, and then you are going to look at the level of the tracheostomy. This is the posterior wall of the trachea and this is the anterior wall of the esophagus. So, normally this is actually a scope which is actually prepared by the long finger group. This has got a beveled posteriorly. Normally the beveling is anterior. If you look at the esophagoscope, the beveling is anterior. Now this particular esophagoscope is beveled posteriorly and it has got a hole here. It has got an opening here so that your needle or whatever you are going to use is going into the scope, not into the posterior wall of the. So you pass a scope into the esophagus, you need a mouth opening for that, and then you pass a needle or whatever it is and make a opening, puncture between the trachea and the esophagus. This is again this is way back in 80s. When we started doing it in 90s, we have prepared this particular needle. We have prepared the needle. This is actually almost like a tunnel. Just like a tunnel needle, it's almost like a cone. A cone needle with a sharp end here with the opening, and this cone needle will directly go into the opening. We are puncturing, at the same time we are dilating it. Dilating it till a catheter catheter can be passed freely into between the trachea and the esophagus. Unfortunately, we never taken this time. This is way back in 1990. And now what exactly you are seeing in the cohort system is the same system, obviously. This we never patented. This needle we have been using this needle quite a few years. So this is how you do pass an endoscope. Now you are going to puncture the posterior wall of the trachea. Usually 5 to 8 millimeters below the mucocutaneous junction. 5 to 8 millimeters below the mucocutaneous junction is puncture on the posterior tracheal wall and directly hit the trachea, posterior wall of the trachea, go through tracheoesophageal partition wall and then enter into the esophagus. Now we have the endoscope. The esophagoscope posteriorly is prevent injury to the posterior wall of the esophagus. So this is how it is being done. Now the needle goes in. Along with the needle, now we can also pass a wire. This wire is pulled out from here and now the whatever stent or the catheter, whatever you are using, goes into the tracheoesophageal partition wall. Now the stent comes up here, the tube comes up here. You don't leave the tube outside here, you push the tube back into the esophagus. So now we have a tube coming and going down into the esophagus. So that is the area where you do. The second technique is what we are using right now. That is the Bromsinger's technique. This is what is called as the Prof system. The Prof system comes with a guide wire, a knife and the wand. And you have a trocar and a cannula. What we have done using a tube, what we have done using a one which dilates automatically as it goes in. Now what it is, here is we are using two separate instruments. You have a cannula and a trocar. Now what you do in fact here is you do the endoscopy, identify your point where exactly you are going to do the endoscope. Now using the trocar and the cannula you enter into the esophagus. The whole trocar and cannula goes into the esophagus. And now we remove the trocar, leave the cannula inside, and through the cannula you pass the catheter. This is the trocar you have removed now, and now only the cannula is left inside, and now into this cannula the tube goes in. Now we have already done the puncture and we have a tube in place. There are two methods of putting a process in. At the same time you can put a process in. You have done a puncture, you have dilated water to whatever necessary area you want to do, and then you can put a process. After second method you can do it is leave the stent for 2 or 3 days. You wait for the stoma. This stoma is within the trachea esophagus form and then put the process. So this is how the process looks. This is the pre-operative. This thing, you have a normal tracheostomy here, and now this is the tube which is going into the thing that they can use. It has got a small tag here which is usually cut here for 2-3 days, and then we cut out this tag up to here. So nobody knows that something is there in the neck. The third technique is where you can use a malleable stent or a fiber optic flexible endoscope. This is where you have if the patient has a trismus or where the lumen is very small and the esophagoscope cannot go in, you will pass a fiber optic esophagoscope and then do this technique. If nothing goes in, you can even pass a wire and you can do an inside out opening. So these are the basic techniques. Now, to keep the shunt in place, you need a process. So what is the process here? The process has got two important functions. Number one, it prevents the reflux. It prevents the gastric reflux. That means something coming from the esophagus coming into the trachea, or the saliva coming into the esophagus and coming into the trachea. So from above saliva, from below gastric contents or the gastric juices. You don't want any of these things to come into the trachea. So it allows only air to pass from the trachea into the pharynx, prevents gastric reflux and salivary leak. So it's a one-way valve. What you are looking at here is a one-way valve. So just one-way valve. When you are swallowing, it closes. When you are breathing and trying to speak, the valve opens up. It's the simplest mechanism which is there. There are two types of valves. One is the indwelling valves and the valves which can be removed and reimplanted again and again. So, when we started working on that, first we had to have, this is a process more commonly we had, the low pressure, the ductal process. This has no wall. It only opens up. It's like a duct bill. It opens like this. Whenever you are taking a deep breath, it opens up. When you are not taking a deep breath, it closes. This is big. This particular thing didn't work out very well. They used quite a bit of ductal process because in the beginning, in 1990s, we only had ductal process. And the process is very expensive. It's almost cheap. It depends upon the price of the dollar. So we had very high and if you have to keep on putting new process again once in 6 months, 8 months, it is going to be a recurring expenditure to the patient. Then you have got Prof non-indwelling device, that's a new one. Now recently the Prof has come out. Prof earlier had 1 and 2, now you have a Prof has come out with 3 process, which is much more advanced process. And then you also now have got a low pressure. The low pressure process opens up even with the low pressure of air and closes when there is a swallow. Because otherwise, if they have to open with the high pressure, the patient has to strain the further voice. So it has to open with the very minimal pressure that has to open up. So you need to have the right process and the right patient. So this is the ductal process. So these are the types of process what we have. See, this is a ductal process. Now when you say ductal process, there is no wall here, it just opens like this. This is a low pressure bronchial valve. It's a valve. And this is one of the valves which came up from the German Groningen's valve, but slowly faded out. We have a bronchial indwelling valve, and now this is a Prof process. These are the various types of process what we have right now. Now, what about the Indian experience? Sanjeev Gohar from Nagpur was also trained by the Indian Orthotics Group. He created his own process, it's called Gohar's process. Costs about 500 to 800 rupees. Works for 6 to 8 months. Have no problems with that. Cheaper process. The second process came from Manipal, was HRA process. But surprisingly, when the process came on, there was a court case by the long finger group. So the process has gone out, totally out of favor. It is not manufactured at all now. The Gohar's process is still available. It's available in Nagpur. So what are the problems we are going to face in the process? If the process is spoiled, we will have a leak. It's a valve. The valve goes, it will leak. That means whenever the valve leaks, he has to replace the process. Right? Second thing is, the process itself, you will need expertise, little bit of expertise to put the process in. Availability. Availability was a big problem in those days. Now availability is not a big problem. Availability was a big problem. Only even from Manipal, where we used to do high volume of surgery, we had to still wait for the process to come. So we used to buy in bulk and keep it, but we need to buy various sizes of process. So that was a big problem in those days. Maintenance, this is the patient-dependent process. Patient has to look after this. He has to put his finger and claw. He has to be trained for that. And the process needs to be clean. There is a brush available for that. He needs to clean. he has to have a mirror with him. It is patient dependent, not the clinician dependent, not the attendant dependent. It is patient dependent. So, and patient has to understand what is doing. Not totally complication free. It has got it has got some complications which are specifically attributable to that. And if the prosthesis is short, he will not have voice. If the prosthesis is long and hitting a posterior esophageal wall, you will not have voice. Right? If the patient is going the spasm, you will not have voice. If the prosthesis is blocked, obstructed, you will not have voice. And another most common problem which you have here is the fungus around it in the prosthesis. It is very common in certain parts of the world. Surprisingly, we don't see that much of fungus in our side, but the fungus is mainly responsible for the spoiling of the prosthesis. So, then you can have leakage of the saliva or leakage of the foot, either around the prosthesis or through the prosthesis. If there is a leakage through the prosthesis, it obviously means the prosthesis is spoiled. If the leakage is around the prosthesis, that means the esophageal stoma has become bigger than the prosthesis. The stoma has become bigger than the prosthesis, and at some point of time the stoma becomes the prosthesis can fall into the trachea and you can activate the prosthesis. You have removed at least 5 to 6 prostheses from the trachea, and finally at one point of time, if the stoma becomes bigger and is not able to hold the prosthesis, you have even put thread and kept the thread around the neck and kept it here, because whenever it falls into the trachea, it is you pull the thread out, and the prosthesis comes out. You can also swallow the prosthesis. If it falls into the trachea, you can retrieve it. If it falls into the esophagus, you can't retrieve it because it goes somewhere else. So you swallow the prosthesis. So there are some of the problems if the stoma becomes bigger than the prosthesis. So exclusion or inclusion. So these are all the common problems which we face. I had at least 2-3 patients who could not afford a prosthesis. Prosthesis is not. So what he does is, he kept a fistula intact. Fistula is intact. Puncture has become a fistula. Now he uses the fistula for the voice. He closes up. You have to close, take a deep breath, close, and then exhale. So air goes from the trachea into the esophagus and you have voice. And for swallowing, you can't have the fistula. Then what is going to happen? He'll aspirate. So whenever he swallows, he'll put it in a tube in. Like what we scented, he bought one tube, he puts the tube into from the trachea into the esophagus, looking into the mirror, and then he eats normally. After finishing the food, takes it out, goes see his job. Our patients are ingenious. So slowly they will learn it. So you have to have a good case selection, good vibrating pharyngoesophageal system. That is what is more important. Good vibrating pharyngoesophageal segment and optimal tracheal stoma. An optimal tracheoesophageal stoma. If we have a very good voice. Right? You get an 80 to 90% of acceptable voice. And more important than the voice, as I said, is sound on that. So actually you can see the stoma there. That type of voice you can get is a Post-laryngectomy and then the case of the surgical voice. Thank you.